Are you ready to go all in?
Let's do this. Let's do this. Let's do this.
And welcome to the All In Practice Growth Podcast. The podcast brings you a different perspective on the dental and medical industries. I am your host, Shane McElroy, and I'm excited for our guest today. He makes me feel kind of bad about myself simply because he does so much, and I think I do a lot, but not even close. So he's a father, he's a husband, he's an oral surgeon, he owns multiple businesses, and he's also an educator, and he probably does a lot of other stuff on top of that. But I really like to welcome to the podcast, Dr. Rick Kapitan. Welcome to the podcast, Rick.
Thank you, Shane. I appreciate the chance to be on the show.
Oh, 100%, man. We should have done this a while ago, but
yeah, that's what I said when you asked me.
Well, we had a big queue. There's a lot of demand here.
I get it. My agent was asleep at the wheel there.
Yeah, seriously, they got to get on that stuff. Tell them to just hit me up sooner. But I do want to get into a lot of stuff with you today because you do have so many different things going on. I want to talk about your many multi locations in the Carolinas, oral surgery practices, kind of what you've got going on with something called Flagship. Your education group with CIA and the Southern Academy of Pediatric Specialties. And so I want to dig deep into that. But first off, if you could start out by telling the audience a little about who you are, a little bit about your background and what you do.
Sure. Yeah. Well, as you pointed out, Rick Kapitan, I practice oral and maxillofacial surgery in Charlotte, North Carolina. I'm very fortunate to be a partner in a pretty big group here in Charlotte. In fact, now one of the biggest in the country. But when I joined back in 2012, I was the fifth partner, and we just opened our fifth office. And then through an entity we call Flagship now, I think we're at, I don't know, it changes all the time, but it's something like 47 offices and about 70 surgeons in our entire network. So it's grown precipitously, but it all started with that core of really great partners and the concept that, we could be this kind of third option, as we call it, not just kind of bread and butter oral surgery, not academic in order to have full scope practice. It's, hey, can you not run a very successful private practice, but practice full scope oral surgery? And fortunately, that's what we've been able to do. That's
awesome. So, and you're based out of where?
My home office is Charlotte, kind of the south side of Charlotte, so to speak. I cover the pediatric hospital 2 days a month, but if I'm not there, I'm here. And then about once a month or every 6 weeks, I'll operate in one of our South Carolina offices, typically in Greenville, Verde, where, Jim Howell, one of our partners, practices. That territory.
I know Dr. Jim Howell very well. What's up, Boots?
Yeah.
Next time he's on, we'll talk about where that nickname came from.
Sounds good. And then we've got an office in Columbia, actually a couple in the surrounding area, and occasionally I'll be down there doing some cases with Matt Pham and the group. But yeah, so main office, Charlotte, a couple of satellite things that I'm involved in on the implant side and the cleft side. But Charlotte's home base.
And you said something there. So you guys kind of sub-specialize within your group, which is kind of interesting. Instead of doing a little bit of everything, which I think you guys all do a variety of procedures and surgeries, obviously, but what is your specialty there? What are some of the other specialties, subspecialties, I should say, within your oral surgery group?
Yeah, we cover really the entire spectrum of oral and maxillofacial surgery, with the exception currently of cancer. So we're involved in the reconstruction of cancer patients undergoing free flap surgery for malignant treatment, but we don't have a surgeon at the moment that handles that part. Short of that, we really cover everything, including temporomandibular joint, from the more routine kind of joint lavage sort of procedure all the way up to custom total joint replacement in the office, by the way, under anesthesia, of course.
I've been to your offices, by the way, and they're all sick, by the way. So any oral surgeon who walks in there blows their mind.
Nice place to come to work. We've got a facial cosmetic aspect led by Wahid Mohammed. Of course, Brian Farrell has further put us on the map. Dr. Myron Tucker kind of established that, planted that flag many years ago, and Brian very successfully picked up and advanced that cause. many of us are involved in orthodontic surgery, but that's almost Brian's entire practice, and he's very literally world renowned in that stuff. So,
100%. I've got
that.
buddies who are like, yeah, because I hadn't met Brian before, and then a couple of my buddies were like, "Do you know Brian Farrell? Do you know Brian Farrell?" He's like a huge. And I'm like, "No, I know his buddies though. I know his buddies.
I know someone who knows him. Yeah, so we've got that going on. As you know, Hunter Dawson, Craig Horton, Jackson Blackburn. We've got some phenomenal prosthodontists in our practice. Just a really cool aspect.
Sick prosthodontist. Both Craig and Hunter, and those are the two I know. I love him. Hunter. I got to see him lecture one time. I snuck into a Strawman event when I was playing for a different team, and I was blown away for somebody so young to like capture an audience and like apply stuff they could actually take to their practice the next day was pretty impressive. I hope he doesn't hear this because I don't want to his ego.
Yeah, he'll want to know why he hasn't been on your podcast. But
he was a long time ago.
Oh, got it. Yeah, when you weren't discriminating.
Exactly. That's exactly right. We're taking what we could get at that time.
Right.
And then I got to go on a trip with Craig Horton, one of the nicest guys
Craig's
I've
awesome.
ever met.
Yeah.
Great dude.
So to a person, we just seem to attract that caliber of individual practitioner, trainee. We're active in academic training of residents that rotate with us. We've got somebody observing probably every other week in town for various reasons. We have 2 full-time fellows, so very, very active in teaching, but still all out of full-time practice perspective. This isn't academia where we sort of practice a little bit and then lecture a little bit. We're in the clinic and we're productive. We just we like the way that it's structured, where everybody has a couple of subspecialty areas, but when you kind of connect them all together like a chain, we cover the perspective, the practice from end to end. And so my contribution to the group is really kind of 2 seemingly very opposite, patient populations, and that is the infant and child, but also up to adult age cleft and craniofacial patient. But then they get kind of swing over to the other end of the extreme, the really resorbed maxilla, the full arch that failed, that has to be redone, the big bone graft reconstruction, remote anchorage type cases. So those are kind of the 2 things that that make up the majority of my practice. That
is so far removed from each other. How did you kind of subspecialize in both those things?
Yeah, that was a good question. I think it just was a byproduct, like a lot of people, a byproduct of the people that trained me. I got what I consider to be very excellent training at Ohio State in residency. Very, not just well-grounded.
I believe it's the Ohio State from the snobs who went to undergrad at Ohio State.
Thank you. And, you do things like win national championships and you get a little bit
cheaters, football cheaters, or at least they got caught.
No,
that's Michigan.
That's the Wolverines we're talking about.
Back. That's right.
Yeah. We had free tattoos, I think was our big scandal.
But that's true. I'm sure that UGA has also maybe done some stuff on the table, but it's if you get caught, and we're really good.
Yeah, that's what it matters. So anyway, back in the Ohio State days, very, very good, anesthesia, orthodontic, bone graft implant training, still good cleft kind of background. But it was really when I got into practice in Orlando that I had the good fortune of working with the late Ramon Ruiz, who unfortunately passed away now about a year and a half ago. But very, very gracious and kind of let me basically follow him around like a puppy dog for a few years before he developed his fellowship. And that just sort of lit a fire. And I didn't really know at the time, I didn't know in residency how much I would love that area. So, I just kind of thought about or went about seeking experience. And so I had like I said, the good fortune of that grounding in residency, built on it in Orlando, built on it with interactions with many, many different surgeons, including in ENT and plastics abroad, many, many years of multiple mission trips a year and seeing dozens of cases each time, just sort of built up that case experience, the knowledge base, and I guess the confidence as well. So the next thing I needed was a practice home, and when I relocated with my family from Orlando to Charlotte, I found very fertile ground and very kindred spirits in my partners, and encouraged me to grow those aspects of what I was exposed to. So some came basically by virtue of residency training, and then the clefting kind of came along a little bit after that, but fit very, very well with, the makeup and the DNA of our group here in Charlotte.
Sure. So you got subspecialties. You said when you joined the practice, there was 5 practices.
Mm-hmm. Yeah.
How many practices do you guys have now in North and South Carolina?
That is a good question, and I'm kicking myself for not doing the latest research before we got on. But
you have so many that you can't keep track of them now.
Yeah, and it changes that fast. So there's CCOFS, which is kind of our main group, but then we formed an entity called Flagship Specialty Services.
Sure.
What is that? Flagship. So everybody's familiar with private equity platforms that come in. If you're in the oral surgery world, Paradigm and U.S. Oral Surgery Management, kind of some of these groups, right? And we met them too, and they're wonderful people. But one of the things that we felt was essential for us was to stay true to that DNA I was describing, where we have a broad scope of practice, and we just didn't feel, and this isn't a knock against any particular entity at all. We had good meetings with a lot of these groups, but we just didn't feel like we wanted to try to shoehorn our way of practice we like to practice into another model, or and many of them would say, well, trust us, you can practice however you want. But when we looked at the offices or the practices that made up their network, nobody looked like us, nobody practiced like us.
Sure.
That we could see. So, and again, there's no right and wrong. It just, is a good fit or not. And so we decided, rather than to just to try to conform, that we would actually just form a platform. And so, we partnered with some private equity people, but it wasn't to roll up under anybody else. It was to build something really cool. So Flagship Specialty Partners was born. That's a couple of years ago now. And since then, what we've done is we've kind of attracted, again, like-minded individuals with practices like ours, or practice philosophies like ours, and or people coming out of training that said, hey, this really, that third option, where it doesn't have to be a choice like it was when I finished residency.
Sure.
Do you want to do big, cool cases, or do you want to go into private practice? It was like, well, can we not do both? And that's what we set up.
That's
so anyway,
cool.
long answer to your question. Yeah, but we're now from Richmond to Fort Lauderdale.
So that's Flagship, right? And Flagship,
yeah.
That's obviously your practices are primarily oral surgery practices. You do have prosthodontists come in. So is Flagship, is it oral surgeon, pros? Like what specialties are kind of in the group right now?
So Flagship has oral surgeons and prosthodontists. We even have dual trained periodontist in our practice as well. So, we're, and of course we have had for years.
Listen, I'm going to interrupt real quick. So it's a prosthodontist and a periodontist. Is that person anal?
Let me tell you, no, he's fantastic. He practices in our Raleigh office, and I mean, my gosh, what a wealth of knowledge. And the truth is that most oral surgeons and behind closed doors will tell you we've got a lot to learn from periodontists. Mm-hmm. They've got a lot of things figured out that we kind of struggle with, and he's been fantastic. Ryan Cook, he's been great. So we've had for a while nurse practitioners. Plenty of anesthesia recovery nurses, anesthesiologists, CRNAs. Mm-hmm. We've added all these.
That makes a lot of sense.
Add-ons. So in-office anesthesia. I didn't mention that when we talked, but it's very, very integral to the model that we run and the kinds of work and the scope of what we're able to do.
Yeah, I'm sure you guys are trained on all that, but at the same time, trying to do those these crazy surgeries while trying to monitor that is that's too much, in my opinion.
Yeah,
so,
I think it just opens the door to be able to offer a level of services or a level of complexity of cases, the scope of which just wouldn't really be appropriate for IV sedation.
Sure.
And you really, the hassles that kind of come along with going to the hospital. I'm a chairman of a hospital unit, so I'm not saying that without living some aspect of that.
Of course.
So I don't mean to criticize it completely, but you get what I'm saying. And if you've been to our offices or any like ours, not the beauty of not just in office anesthesia, but having the anesthesia department in your practice. Not have to contract
100%.
out, not have to. You actually can schedule in conjunction with them and work with them day in and day out to craft these.
Well,
schedules.
and at y'all scale, that's manageable, right?
That's
Individual
right.
person running that may not be an option for them.
True.
So I want to I'm actually really curious about this. Sometimes I ask questions for the audience. Some of these questions are for me. So,
All right.
I actually did look up on y'all's website, and I think within the Carolinas, you have 23 uh, CCOFS specific offices, and I think it's
Yeah,
40 surgeons, which is
that's correct.
which
Yeah,
is
including
wild.
our
So,
latest hires. Yeah.
I'd like to ask you a few questions about, all right, how did you scale that? But then also,
Yeah.
like, okay, when you get that many, how do you make a decision? So,
Yeah.
um, let's say you're starting at 5, you're getting into the
Yeah.
group. How do you determine how you're going to expand? I've
Mhm.
talked to different groups, whether it's, dentists doing multi location dental practices, some oral surgery practice, or some, I've talked to a lot of people who have kind of across the board, but
Yeah.
how did you guys, do you guys determine it based, we have the surgeon, we want to build around them, or
Mhm.
they have an office, we want to bring them, like, what is y'all,
Yeah.
let's start, was your model, because that may have changed. What was your
Sure.
model as far as acquisition or just growth in general?
Right. Yeah. I think if you go back to what I'll call the early days, even though that by that point our practice had already been around for over 2 decades, but in those days, it was a lot of like super obvious pins on the map where there was a good population center. Where are they building schools? Where do you have 2 Target stores within a short
Sure.
radius? Obviously, to some degree, competition from oral surgery, but honestly, that one didn't really, because we practice differently. That's not one that's ever really affected us or factored very much into the mix, other than to say that it might be a reason to go to that area, if that makes sense.
Sure.
Um, but a lot of it in those days was personality hire, I call it, where you say, all right, well, we may not have a true need as we see it now from a demand standpoint or a patient volume standpoint, but we can't let this guy go. We can't let this girl go. We'll figure it out. And so I think that's true of a lot of organizations, not just in dentistry, but a lot of organizations sort of, gosh, we just got a feeling, we know this is going to be a rare opportunity to get somebody and have them grow with the organization or learn from them. So we'll worry about the perfect timing later, but we need that skill set, we need that personality, we need that vision, whatever it is. So I think that guided us honestly quite a bit in the early days, and it was fun to sit around our business meetings back then when there was only 10 partners. There were 10 surgeons and we were all partners.
Sure.
And before we started having associates and whatever. And it was kind of like United Nations. Everybody kind of
Yep.
brought a different skill set or perspective to the group, and they got quite lively and animated. Sometimes we didn't always agree, but we could always walk out of there, slapping each other on the back, and you leave that part behind and just grow the business. So a lot of ways I kind of miss those days. The growth is great, but that part of the reason that I'm active in startups is because I love that entrepreneurial kind of phase and
kind of the build.
The build, yeah, exactly. It's
build.
a little bit, it, right? You've done and are doing the same thing. So it's a little scary. It's the 2:30 a.m. What am I not doing right? Kind of wake up stuff.
Yep.
But it comes with that sense of satisfaction that's important. So moving on from that, then it became a little bit more corporate. Danny Kitola, I have to mention. Danny was our chief executive everything for many years. And he really kind of put up with us, but sort of helped us steer and things back on track. But I'll tell you, it got to the point, Shane, part of the real calculation that resulted in us partnering with Flagship Specialty Services is that a couple of things. One is we were realizing that we were probably at the point where we grew it as much as we were going to. Not that we couldn't have grown more, but we wouldn't grow at a pace or a rate that we could when we reached a certain scale. That actual business people could, right? And so we recognize that as number one. Two, the practice,
which is kind of its own subspecialty within an oral surgery practice.
You could think of it that way, right? And there are just things that we cannot be and have not been equipped to do or know that could really drive the profitability and growth and success of a business once you get to a certain size. So, there's this concept that we talk about, especially in the nonprofit world, called founder syndrome.
Yep.
And that's where there's someone just can't let go of the steering wheel, and to the detriment of what it was they started and they created. And so I think it's a healthy process. But the second thing is, we were almost victims of our own success because we were becoming so successful, and a lot of practices get through there faster than we did. But that there really isn't anybody coming out of residency that could afford to buy in, frankly, at 1/10 of the value, with student loans and
It's
so
getting
on.
harder and harder for everybody.
So
to
then
do
what do
that
you
now.
do? Do you have just long-term associates? There's good and bad to that. Do you sell shares? So it kind of got to the point where we needed a succession plan. And then the third thing was, as we looked around the table, everybody was in this like 12 to 15 year cohort, right? I mean, we were all
Sure.
kind of moving through the age progression and the career progression kind of as a block. And, we didn't have a lot of senior partners to turn around and sell their position to
I
somebody
didn't really
younger
think
too.
about that, but the bigger you get, you really do have to have like an even scale of age ranges, right? Take
Yeah.
over and refill.
Well, you do if you follow the traditional model, but
Mhm.
one of the reasons that I think this expansion helps so much is kind of the way that like insurance works, right? Where you kind of pool your risk, you pool your resources, so to speak, and yes, you give up individual decision making control, but you bring in experts in their field, and now you're a part of an entity, and now everybody is sort of like I don't know, you almost kind of level out with everybody else because now it isn't somebody buying into your group. You're part of this big collective, and we're
Well,
partners
unlike
in
an
it,
insurance
technically,
company,
but
because you guys are still making moves where they would just deny,
yeah,
deny,
yeah,
right?
yeah. Fair point. But yeah, so I think to wrap up the answer to your question, I think our growth strategy went from, hey, who are going to be represent the core, and I don't just mean partners and hires, but I mean staff and
Sure.
support staff and
Oh
so
yeah.
on. And then when we got to that critical mass size, whether PE was happening or not, we probably would have looked at a transition like that, just to get us into the next category of growth, because I think we would have maybe been the reason we didn't grow more if we
So I
had
think one of the
continued.
things you were saying was like, when you see talent, you got to attack it, right?
Yeah,
Whether
yeah,
even if you don't think you need to, that's like LeBron James. You got the number one pick, LeBron James there, but I need a center,
yeah,
right? Or let's go back to
yeah,
the early '80s when Jordan was coming out. Uh, let's draft Sam Bowie instead of
yeah.
Michael Jordan because
Right,
we have a need to fill, right?
right.
And I think if you just, in my experience, every successful business that I've ever seen
Yeah,
prioritizes talent over
yeah.
exact fit or need,
Right.
right? Because you can grow into that fit or need a little bit if you have enough talent,
Yeah,
but there's a lot of things that you just can't teach, like drive or the
yeah,
disease that you have. You want to keep growing, keep doing new
yeah,
things, learning more
yeah.
too. Of all the diseases, I'd say it's a pretty solid one to have, though, right?
Yeah, I think it has pluses and minuses, but I just it's pretty addicting. I tell my kids, I said, I feel like life is like a money booth, and the dollars flying around are opportunities. You know what I mean?
Yeah, for sure.
I
I
beat
want
my
that one. I
alarm
want
every
this one. I
morning.
want that one.
Yeah, and they don't all make sense. And then you said something earlier that resonated with me, because a very wise person told me not too long ago that it's not hard to pick out the good opportunities from the bad ones in life. The hard part is saying no to some good ones, right? Only
Oh
saying
yeah.
yes to some really good ones, and that's really hard if you're wired the way you and I are, and a lot of people that that achieve and they're kind of geared that way is ever looking at an opportunity and feeling like, yeah, I can do that. Sure, put it on my plate. I can handle it. So I'm slowly learning that lesson. In the
It's
middle of
a
my
it's
career,
a
but
it's a
it's a hard
hard
one.
one, right?
Mhm.
But I think one of the things that you've done really well about being an entrepreneur, but engaging both indirect and direct elite partners,
Yeah,
right? And I
right.
think that allows you to have a bigger scope,
Mhm.
a bigger reach, try out a few more opportunities than if it's just you. Well, there's only so much bandwidth, and that was always my problem when and I like to say years ago, it wasn't that long ago, to where I had a conversation with a couple of different mentors of mine. I'm just like, could do all these things yet, but how many can you do great,
Yeah,
right?
right.
And I was like, oh shit.
Yeah,
Not all
yeah,
of them for sure. So I think that
right.
is a disease of the disease of entrepreneurship is
Yeah,
wanting to do everything. But you've done it really, really well. And
yeah.
speaking of
Thank you.
that, let's kind of roll into, I want to talk about CIA, because I actually,
Sure.
we had I think talked a couple times, and I knew some of your other partners and some of your other
Mhm.
businesses and things, but I hadn't got a chance to meet you. But he's like, oh, Rick Kapitan, nice guy, he's great, he's an amazing teacher. Especially when I was in implants, all on X, right, learning
Mhm.
all of that. And then I got to meet you actually at when I was working with ZimV, formerly Zimmer
Yeah.
Biomat. You were actually teaching a course at the same time. I was there for a different course, and it was really nice to meet you and like listen, you've done a lot of really big things. And I know a lot of people who've done other big things and they weren't as humble or as kind as you are. So that was
I appreciate that.
refreshing
Thanks.
getting to meet you that way and just feeling
Yeah.
like, oh, this guy's, he's laid back. He's cool. And he doesn't, have a giant ego, which
Yeah.
is really refreshing.
Yeah. You'd think I would have made it on your podcast a little sooner. So I haven't said all that.
Well, somebody's got an ego a little bit then and their feelings hurt.
Yeah. Well,
I'm
it's because
sorry,
Hunter's going to remind me that he was on first, but that's okay. We'll get by that.
Well, we get the riffraff out of the way and we just move our way.
There you go.
Is
I
what
like
we
it.
do.
I like it.
You could tell him I said that and hopefully he hears that. So let's talk about, all right, you've got CIA, which is Clinicians Implant Academy. And again, I love that name as a marketing guy. Like all these things are whizzing around my head. I'm like, we could do Jason Bourne. We could do 007. We could do, a billion other spy things. Right.
Yeah.
But first of all, let's talk about like, where did you get into and let's focus primarily on dental implants right now.
Yeah.
How did you first get into implant training? When did that start and how did it evolve into what you're doing now?
Yeah. I think so. The very beginnings of it at Ohio State, it's a residency program, but it's right down the street from a dental school. And I think anytime you have the ability to do that, there's some advantages to that and collaboration and so on. But I think that was the beginning of just saying, hey, I think I like teaching people. I think I like that light bulb moment when it goes off and you kind of move them, and it could be something simple or something kind of a little more complex, but just, they start out just not really feeling comfortable with XYZ, but you kind of say, hey, look at it this way, not that way. And then they take off and, and they don't need you anymore, or they advance or whatever it is. So I think the very, very beginning of it was because we would staff the student oral surgery clinic as residents. And let's face it, we didn't know that much more than they did then, as a first or second year resident, but just the openness of the exchange, right, of the information.
Sure.
So that was kind of the beginning. And then in my practice transition from Florida to Charlotte, I actually did a lot of surgery for Clear Choice for about 2 years. So
that's a great entry point.
It's fantastic. I think there are some opinions out there, and especially in oral surgery or maybe in prosthodontics about them as an entity. All I can tell you is the couple of years that I was involved, it was a very, very good experience. It was very pro-doctor, pro-patient. Yes, they were smart about the business aspect of it. And I'm not saying it's any different now, but I can tell you for sure, those were really good years to be a part of.
I've heard that from a lot of surgeons who've been there, and talk about reps, how many reps you get to do with full arch cases and difficult cases too.
In 2 years, over 500. So it was very, very good. But anyway, that experience sort of catapulted me and this was a decade plus ago, but to, I guess being at the forefront of what was being done or what was being done, routinely in that sense, right? Like we weren't doing cutting edge research, or I wasn't, but what I mean is I got a way more advanced, ramped up experience than I would have gotten in many, many years of private practice, trying to get these cases to come in the door, find out who I was going to do them with. And so I kind of look at it as a fellowship, really, in that sense, but one with a lot of autonomy and that allowed me to kind of develop my technique and think about it just a little bit differently in ways that maybe work for me, maybe not somebody else. But so that then transitioned to when I got to Charlotte, and I really wanted a community of restoring doctors to work with. We didn't have prosthodontists in our practice in those days. We had some, of course, in the community. And so that sort of morphed into,
so kind of open up your eyes to what that could be, which most surgeons wouldn't unless they've had that experience.
Exactly right. And the confidence to say, hey, look, I could take a lot of these cases that look like they're going sideways and maybe drag them across the finish line, or at least put them in the strike zone for even an inexperienced restorative person. And so the next step I thought was to develop basically a full arch study club, and we called it the Envision program, and that's where the Envision clinic that we now have came from. But I think that was a good 5 or 6 years of bringing restorative doctors together to talk about that aspect, patient identification, treatment planning, finances, all the little nuances that well that go into not just knowing about these cases but doing them successfully. So that was really sort of the big leap, was to get up in front of 50, 60 restorative docs and kind of talk them through the series, do it again, the cases that came through. And then I started documenting cases. And so when then Zimmer had the opportunity and they needed somebody to go to the podium, I said, well, I've got a big backlog of documented cases that were recent, and I've got pretty much a number of lectures. So let me try it. And so they were really the first ones to kind of engage me as a quote unquote KOL. And to this day, I speak more for them than I do anybody else. And I've really, really enjoyed the relationship.
All right. So I got a question for you. Are you using the TSV implant, which by the way, like great implant, but not necessarily the best initial stability in those types of cases? So you're good, right? If you're doing that, or are you using their new TSX?
Yeah, more the TSX.
I love that implant.
Yeah, more the TSX these days. And then of course, I work with in-house prosthodontists, and so sometimes, they like to steer things towards connections that
Dr. Hunter Dawson really likes Strawman, and they'll be like, "Hey, I don't play on any team, so I don't have any favorites anymore." Right? There's lots of good systems, but I'd seen so many of your cases, both like on Implant Compare, working with Blake in the early days, being like, did he just get that primary stability with TSV?
Yeah.
That's pretty.
There's a way to do it. And I kind of, spent a lot of years trying to teach people how to do it. I still think it's a very fine design.
Great.
I think it's the reason it's been around for a long time.
Oh, for sure.
And now ZimV, they've just been so pro education for so long. I think it was maybe even, to their disadvantage, because they study things for a while and then they roll out really comprehensive, training programs. So they may not be the first, to do anything, but when they do it, it's really good. It's done to the nth degree. They stand by it. So,
and shout out to Ken Varner. He's the leader of the education team at ZimV. I was like a kid in a candy store when I got there, because I had never seen like facilities like that, or like, oh, it's $400 and we pay for your flight and your hotel. And I'm like, what?
Yeah.
Right. And,
but, and I think that just shows the commitment to learning. And so, so I felt very at home with that philosophy, because, they've never asked or suggested that we cut corners or do anything that we wouldn't do, clinically, if the cameras weren't rolling. It was like, it's always been on the up and up with them. And like I said, I enjoy that relationship to this day. The thing though, across the board that I saw, Shane, and one of the reasons, and I've talked about this going back a couple years, that led me to want to start the CIA isn't because I was unhappy with the other speaking arrangements and, the other companies and that kind of thing. It's just that, I recognize that there are limitations to the kind of, the degree of the education that goes on when it's a one-off event here and then back again in 6 months, and the next time it's in a different state. So you're transferring a lot of data, but I don't know that I would consider it ideal in terms of education. And I don't, I'm not sure anybody's getting it right. This isn't a knock on implant companies per se. I just mean that method where people leave their practice, they come for 2 days and they're supposed to go back and dramatically overhaul how they practice is a little far-reaching, and I've thought for a long time that what's really missing is the mentorship aspect of it, right? So some people have had that and figured it out, and hats off to them. But so I think there's a place, right? I think there's a place for the exposure to the treatment, exposure to the product, get it in someone's hands, teach them a couple clinical pearls, and then kind of like send them on their way. But CIA gives me the ability to kind of design the courses, set a schedule that I know that I can commit to and build on, and then have these people kind of circle back to us and go to level 2, go to level 3.
So you're saying level 2, level 3, but what are those level 1, 2, and 3? Like, what are you teaching?
Question. So level 1 is your basic oral surgery, atraumatic extraction, basic socket preservation, sort of stuff, simple implant stuff. Level 2 would be your ridge augmentation cases, all the way up to sinus lift, that in that subcategory, custom bone blocks, custom mesh, that kind of stuff.
Nice.
Level 3 would be your basic full arch, so your all on X type of things, and pterygoids and that sort of stuff, and then kind of overlapping.
Pterygoids are, I'd say, above basic for a lot of people.
Well, agreed, and that's my point. Is there's like an overlap with that up to full arch, right? Or up to remote anchorage, as we'll call it, right? So, a lot of the same principles. So that's sort of a little gray area, because you could have some super simple quad zygoma cases, and you can have some
Yep.
really complex all on X cases. So, that's a little less defined, but essentially that's the progression that I like to think about and take people through, is from, hey, I'm not super confident in even getting teeth out routinely without blowing everything up. All right, now maybe
Yeah,
that
that is
person's
not a great
never going to get
foundation for your implants then.
right, and it might not, and it's not like everybody that starts at level 1 has to get to level 4, right? I mean,
Sure.
I think we're doing good if someone moves up one level from where they start. I think that's
As
a
long as
great
you're
goal.
always moving up, your
That's the point.
pace is your
Yeah.
pace.
Yeah. So I'm not one of those people that feels like, anybody with a dental degree can do quad zygoma surgery, right? If they just
Sure.
get taught the right things. I think I'm still a big believer in specialty level care and specialty level treatment, but I'm also a believer in education and the fact that if someone's willing to take that next step, that they ought to be, rewarded with good, solid training, education, support, and help. I mean, that's, even as specialists, that's how we got to be specialists, right?
Sure.
We advanced the ball. So I'm not trying to condense oral surgery residency down to 48 hours. I'm not trying to, overstate what we're able to achieve. I'm just trying to be a showcase, educationally for different products and techniques, so that wherever you start, you can move maybe one step up the ladder at least, and then take that back. And so instead of just like grabbing all these one-off education opportunities and then go back to your practice and trying to figure out how they fit together, why don't you help us just sort of assess where you are and get one, maybe even 2 levels up from where you are, but with those touch points afterwards, so that you don't lose
That's
your
what I
nerve
was going to
even try
say.
these cases.
That you talk about mentorship, touch points, right? That having consistent person or group of people to go back to, because really what you need is, like, you can learn something, but you need to go try to apply that. Once you apply it, you may still have questions, and like, all right, I ran into this in a real world scenario. What would you do? And having that ability, I think, is next level.
Yep.
And
that's really where the existing model breaks down, in my opinion, right, Shane? Is that like, we can, I can spend 48 hours with you. You can show me all these really, really cool things. But I go home and I'm like, all right, well, that was in that context. What about the context of the patient that just walked in the door? And what about when this complication comes along? Then, what does that person do? So, like I said, I'm not trying to stretch, the definition or the goal of what a 2-day implant, meeting can achieve, but that, I'm just simply saying that I think, it's past time that there was more opportunity in the marketplace for someone to grow their skills episodically with the same people, but it kind of advance over time and with support in between.
No, I would agree completely. But let me ask you, so a couple of things just to clarify. Who comes to your courses? Is it specialists? Is it general dentists who want to up their game? Who comes to the courses?
It's a broad mix. I kind of think of it like a pyramid.
Sure.
Where the base of the pyramid is honestly a lot of I have a lot of DSO clients that and they kind of envision their doctors as a pyramid where they want everybody at a certain competency level.
Makes sense.
And then if everybody's there, then a few more will rise to the next level where they're doing the next most advanced, and then up from there. So the most successful DSO clients I have some sort of internal graduated process where they get this education. But truthfully, I mean, this isn't really any different than what I taught as an oral surgery resident to dental students. So, I think that's really, I see that as completely appropriate, so to speak.
Well, within that pyramid type structure, all they have to do is look up, and and if you do it really, really well, you can actually have internal mentors as well.
It's exactly right. And I could, offline, I could tell you a couple that I'm super impressed with how they do it, because, they sort of set the pace, and then they engage with the CIA to kind of carry out. And I have some involvement in kind of crafting the courses, but They already come to the table with a great internal plan, which is awesome. So that's a big thing right now. It has been for the last couple of years. So that's kind of the base of the pyramid. That's our kind of typically level 1, level 2 CIA courses, where they're coming in, and quite a few of them are cadaver based.
Okay, I was going to ask you that. So a lot of cadaver based. Are they shadowing you like in your regular practice? Like, what else goes on?
Unfortunately, we haven't been able to crack that code yet, just because, I mean, our office is so busy. Our cases move so quick. It's been difficult to be able to accommodate even the people that want to we're training to come in and observe. So we're going to get there. I don't know that it's anytime real soon, but what we have already done and have for years, and you've been a part of them, are cases where we're doing the case, but they're right over our shoulder. So live patient surgery in the sense that we're doing the surgery, but they're in on it. They're answering questions in real time. They're getting the restorative side, they're getting the surgical side, we're getting all the business Q&A as well.
And your faculty is pretty impressive as well, I have to say.
Yeah.
You got a lot of great surgeons, prostheticists, you got business people, you've got lab techs, you got digital folks. Like it's full scope for sure.
Yeah.
And I think if you're going to do full arch right, you have to have all those different perspectives. That's the one thing that, people are like, a lot about full arch. I've been in over 1,000 cases. And I learned more from the lab at first, and then I learned from the surgeons, and you have to have that perspective, which is why Clear Choice is so valuable, because you get to see so many cases.
Yeah.
What looks like on a CT or at a pan looks like a slam dunk. You get in there and they're like, oh shit.
Yeah. And part of the learning that was so great about Clear Choice is I was steps away from the lab guys, most of the guys that were doing these cases. And especially when they got to know you, they were brutal about, hey, come here, let me show you the situation you just put me in by the way you did this surgery, so I'm really grateful for that opportunity.
Great perspective to have as a great lab guy.
It's great. So the majority of the people that take our CIA courses by number are the DSO type level 1, level 2 courses, just because the demand is so big.
Sure.
But then as you kind of move up the levels, and I think that sort of makes sense, we tend to get either more experienced general practitioners that have been doing implants for 15 years. And, they kind of know, the progression, right? They're not overreaching compared to where their base is. They're actually really thoughtful about, hey, I'm at this level, but I think I feel good about continuing. So they just come and kind of probe that. And then typically, and there's always exceptions, but typically if we're doing quad zygoma cases and zygomatic cadaver cases or pterygoids and all that stuff, that's typically more your surgeon, kind of surgical.
Sure. So if you're a surgeon out there, you don't want to pop eyeballs out, give Rick a call, right? He'll teach you how to do it, right?
It's frowned upon.
I've seen a couple of weekend zygo courses, and I'm like, I just think that's a bit much.
Yeah, I think it's deceptively complex, and what I mean is it's a very, very straightforward treatment plan or treatment objective. Just a couple of drills. I mean, the whole thing sounds like kind of a slam dunk, but there are so many nuances to that. I don't think there's any less to that than there are to full arch surgery. In fact, I think there are plenty more, and it isn't just by the virtue of the anatomy where we're operating, but just where the forces are and how that bone is so different than alveolar bone and on and on. But so that's kind of the breakdown, sort of the pyramid of CIA courses that we see.
And if somebody's, before we get to the last topic, which I really want to get into, if somebody's interested in going to your course, we're seeing which courses are available, or just reaching out to see if maybe they do something custom, where would they go?
Yeah, so CIA-implants.com. You'll see the calendar. It's important to point out that most of what we end up doing for clients is custom, in terms of courses.
Nice.
So you'll see level 1, 2, 3 listed, but unlike the typical scenario where, hey, I'm doing a level 2 course in December, who's coming? Like I said, that in my mind, that fosters that one-off approach. What I like to do is I work with DSOs, I work with dental implant companies to build the classes.
That's awesome.
And so when they have, a quorum, and we've had as few as, 8 people, and we've had as many as 20. But what I would do is, like, someone reaches out to us, we're like, hey, we'd like you to contact this company. They're building a class together. And then they're all of a sudden now everybody's already grouped. And the importance there is we can do things like, webinars before they come. We can set some didactic boundaries and go over some basics. In this format, a week or 2 weeks before, get a lot of that stuff out of the way. And then when they come, we can hit the ground running. So
that's awesome. So you dive right into the hands-on.
Yes. And still get the didactic, still get the full CE that we offer, but break it up. So we're doing like, hey, let's do it in the evening while you're at home. And then when you fly in, maybe you don't have to come for as long, or when you do, we can hit the ground running faster, or we can get to those higher level questions. So, that's what comes from being able to partner with industry to build these courses, in my view, not just, put out the calendar and take all comers. I mean, there's a way to do that. I get it, but it's not that's the way we prefer to do it. I want long-term industry relationships. I want the ability to kind of craft that curriculum.
And then whoever's there gets exactly what they wanted to get.
That's exactly right. Yeah. They come knowing what they want to get out of it. They know if they're in their right class to begin with before they get on the plane.
All right. Well, Rick, I really appreciate you being on the podcast. It's been almost an hour already, but I didn't even realize that until I just looked now. But we'll have to do another episode sometime simply because you have so many different things that you're doing. We could go down rabbit hole after rabbit hole. So thank you for your time today. And guys, we'll catch you guys on the next All In Practice Growth podcast.
Thanks for listening to the All In Podcast. See you next time.